Okay.
Good evening. Welcome to the guideline-based case studies by family medicine registrars. Today is the 5th session, and today's presenter will be Dr. Gayatri Nanayakar, who is a third-year registrar, currently working in Ragama. And before starting the session, I would like to invite Madam Malkanthi Galhena, President of our college, to give a brief introduction.
Okay. Thank you very much, Prabhat, for your kind introduction. And I would like to welcome you all to this session tonight. On behalf of most of the participants, I know that our registrars and the senior registrars, and we have invited for the participants who are waiting to sit for our MD screening program, the exam as well. So anyway, this program is mainly conducted through the College of Specialist Family Physicians in order to give you the guideline-based management in first contact care for the patients who are coming with different reasons for encounter. So when you are, the thing is, you have to, understand for each and every the encounter, right? Even though that patient is having the very simplest, the underlying cause for that reason for encounter, but you have to think about, the in depth to exclude underlying red flag diseases by asking symptoms and going for the examination to exclude those red flag symptoms and signs as well. So each and every patient who comes with different symptoms, this is the key, the message that you have to take into your mind. Always think about, the possible underlying red flag diseases and the symptoms and signs to exclude. So case-based discussions, right, will help you to, think about in that way. But, always our management should be focused for the guideline-based management. That is the scientific, the best evidence-based management that we have to do. We can't do whatever we think here. So there are, the international guidelines and the local guidelines mainly based on those international guidelines, and they have, the Ministry of Health has prepared those such guidelines for each and every, the diseases to cater for the country and our population. So you have to always being registrars and the being, the trainees in this discipline, for you to get the qualification in diploma as well as the qualification of MD. Always, keep that in your mind to, go for the evidence-based management by, the understanding and keep updating the evidences through the, the guidelines. Guidelines are the very important thing that you can always go through and better practice accordingly. And more than that, the local guidelines and the international guidelines for specific diseases there are. So you must know what are the guidelines that you have to be aware and to get the, the practical points. Reference of those guidelines are very, very essential. And as well as, so that you have to know when, not only that, there are some articles, right? Some, the scientific articles, the giving analysis of symptoms and giving knowledge, the aligned to the guideline based management. So that is the rationale of management of patients. So whenever you are going to take the history from the patient, very first thing in first contact care is establishment of a very good, the doctor patient relationship through establishment of, the proper proper establishment of the rapport and as well as the communication, so that you have to use your skills. There are 5 skills that you have to practice through this consultation, whatever the encounter for the reason. So that is one thing, is the establishment of the consultation skills. Number 2 is you have to think about your data gathering skills according to the specific symptoms and the duration, thinking about the possible differential diagnosis. Next thing is, narrow down the differential diagnosis at the end of history taking by asking about psychological, social, and the hidden agendas as well. Then go for the examination skills with the very correct technique and identifying the correct, correct systems to examine according to your history, right? And then the fourth thing is, once you detect any signs and according to the symptoms, so you can come to your clinical diagnosis, and then you have to counsel about the patient. What do you think, and what is the, for an example, if patient is having migraine, if you think, then you have to convey the message that migraine is this, it's a constriction of your blood vessels in the brain in a particular area. So with that, the narrowing of your blood vessels will provide some ischemia accordingly. It provides some chemicals to dilate to the normal side, but with that, with these chemicals, you will get, the headache due to the stretching of the blood vessels, and some due to some abnormal chemicals, you will feel, the nausea, the vomiting, and whatever this thing. Like that simple way, you have to tell the patient what you think about and what is the possible underlying clinical diagnosis. Then go for the investigation. Next is management skills, which comes under reassurance investigation, possible minimum investigation, and as well as, the best evidence-based management, pharmacological, non-pharmacological, follow-up, and reassurance. So that is the guideline that we are going to present this case today. Mainly the patient, this is the real case scenario that we got at the training in the Base Hospital, Panadura, this registrar, so Dr. Gayatri. So I will hand over this. What is noise, Prabhat? Please mute your this thing, speakers, and otherwise its noises will come. So I will hand over this to so we are going to do the series of case-based discussions in order to provide, the guideline-based management and the art of consultation in general practice. So having that, the introduction, I will hand over this to the Dr. Gayatri. She was my registrar to that until the last week, and we have found the real case, and we are going to apply, she's going to apply for that evidence-based, the management and the guideline update to you, right? So it's over to you, Gayatri. So kindly please, the listen, and it's interactive session at the end, so you can have your own questions to clarify the matters. Okay, it's over to you, Gayatri. Thank you.
Thank you very much, madam. Today, my topic is, as you can see, it's obesity. So this is a real patient who presented to the Base Hospital, Panadura. Sorry, can you hear me well?
Yeah.
Yeah, okay. That this patient was managed under the guidance of our madam. This one is stop. Yeah. So this is the case history. This patient is a male patient. He's 47 years old, diagnosed patient with hypertension. He came for his routine follow-up for hypertension. And but when he enters the rooms, obviously we can see he's a bit obese. So that patient didn't have any symptoms of chest pain or shortness of breath on exertion, but patient complained of bilateral knee joint pain for few years. Other systemic review is normal in that patient. So in the family history, that patient's father has had a myocardial infarction at young age. And that patient is only on losartan 50 milligram BD and amlodipine 5 milligram BD. So as I can see, the patient is in obese side. I ask about the dietary history, and it says that he is taking 6 main meals, mainly consist of rice and 3 cups per meal. And also he is consuming large amount of sugar also. This patient is a carpenter and he's physically active person. Even though he eats a lot, he works a lot also since 8 a.m. in the morning to 8 p.m. in the evening he works. And he's the breadwinner of the family, and his wife is having rheumatoid arthritis and suffering from major disabilities. And he has 3 sons still studying. So he's having a lot to cope at home also. But there's no features of depression. And he understands he has the problem of obesity, and he's motivated to reduce his obesity. So on examination, general examination, his BMI was 36, and he has acanthosis nigricans, and blood pressure, pulse rate, they were normal. And
Gayatri, shall I disturb you? What
yes,
about his social behaviors?
he is a non-smoker and non-alcoholic. He has no any habits of that concern, madam.
Family history of obesity?
There's no family history of obesity.
Okay.
And in examination, the cardiovascular system and other systems examination normal. His BMI is 36, and even I examine the bilateral knee joints, there were mild swelling, but there's no significant effusion. And crepitus was there. He came with his investigations. In investigations wise, even though he's not diagnosed with diabetes, his HbA1c is 6%, and fasting blood sugar is in 118, and all are in pre-diabetic range, and total cholesterol is 268. It is in high side, and LDL is 100, and his liver enzymes are like 2 times elevated, and it's mainly ALT. And his ECG was normal. So the problems I identified in that patient is he's already hypertensive and controlled with drugs. He has dyslipidemia, and he has obesity. It is 36 BMI, so it is under the category of 2 obesity category, that is morbid obesity. And he's having bilateral knee joint pain. More likely, it's early osteoarthritis, and he's also having elevated liver enzymes. So today, even though he has many problems, today our main topic is to discuss about his obesity, because he was so keen on reducing his weight, and we did a pretty good job with this patient because he was already motivated, and it was easy for us to address his problem. So before going to how we manage the patient, I will discuss the topic, the obesity. According to the obesity guidelines, obesity is a chronic, progressive, relapsing, multifactorial neurobehavioral disease characterized by an increase of body fatness, which promotes adipose tissue dysfunction. Abnormal fat mass, physical forces resulting adverse metabolic, biochemical, and physiological health consequences. It's a bit lengthy definition, but what it says is increased body fatness due to the adipose tissue dysfunction, and which releases the chemicals, resulting bad consequences. So the main thing we have to gain here is obesity is a disease. As diabetes, hypertension, or bronchial asthma, we have to regard it as a disease. So in obesity, it affects all age categories, from children to older people. And it is one of the leading cause of disability and death in worldwide. So this was, at first it was not recognized as a disease, but in 1948, WHO has recognized it was recognized as a disease by WHO, and in American Medical Association recognized it as a disease in 2013. So the main thing as doctors, what we have to understand is to see this with empathy, because this patient it is not his fault to get obese. That is what we have to understand, and that is what they emphasize in the guidelines. Because obesity is not a personal choice. They have no choice, but they had this because of a disease thing. This is a disease caused by complex interplay among genetics, the environment, and many other causes. So, as this is a disease, there's treatment. That treatment consists of nutritional, behavioral, medical, and surgical treatment, just like any other illness. Something about the prevalence and things about the obesity. WHO estimates in 2016, 39% of adults are overweight and 13 are obese. And these figures are increasing in recent years. And this epidemic is spreading in South Asian region very rapidly. And in local data, in STEP survey, 23.4% are overweight in Sri Lanka and 5.9% are obese. And in that category, 10%, 2.2% are children. And it is also more common in urban areas. This is the map of obesity. It is mainly in developed countries, but it's coming to our region also. So what are the causes for obesity? We categorize it into mainly 3 categories. It's environmental, genetic, and secondary causes. Under the environment, it's the diet and the physical inactivity, high-calorie diet and the physical inactivity. And genetic causes, there are monogenic causes like leptin deficiency or resistance, and melanocortin receptor mutation. And there are chromosomal dearrangement, which cause syndromes like Prader-Willi syndrome. And the secondary causes, and there are polygenic causes also for the obesity when we consider genetic causes. And there are many secondary causes, and that means the diseases that give rise to obesity. Those are Cushing syndrome, hypothyroidism, hypothalamic lesions, and polycystic ovarian syndrome, and drugs, especially the steroids and some antipsychotics and contraceptives like oral contraceptives. So those are the things. These are the genetic disorders that give rise to secondary disorders that give rise to obesity, like hypothalamic pituitary defects. And this is a syndrome called small beetle syndrome, which causes obesity. So how do we measure obesity? How do we say one is obesity or overweight or it's normal? So it is mainly the obesity is increased fatness. So we have to calculate the fat, but it is difficult to calculate the fatness in a routine clinic. So what we measure is the body mass index. So body mass index is compatible with the fatness. So there's an equation. If we get the BMI, we can calculate the body fat percentage. So BMI is we all know how we calculate the BMI. We have to divide the weight by the square root of the height. And the BMI is the first one that comes under measurements of obesity. And the second one is standard skin thickness. Usually we use subscapular, biceps, triceps, or suprailiac region for the this to measure the skin thickness. And the waist circumference. When it's waist circumference, we measure the point where the iliac crest is. And waist hip circumference ratio is another thing. And we can use DEXA scan, CT scan, abdomen, and MRI scan if we want more extensive measurements of obesity. So this is the classification of the obesity in the worldwide classification. So you can see when it's more than 25, it's overweight, and it's beyond 30, it's come to the obesity category. So our patient who has 36 of BMI is coming under the obesity category 2. So, but even though this is the world-wide classification, when it's come to the Asia Pacific BMI, the threshold is low, and it's becoming even low. This is the one I have got here. The normal range is from 18 to 23. So after 23, it's overweight, and obese category is more than 25. So our threshold is very much low. So we are going, so we have to have a very low BMI compared to the other part of the world. So in South Asian countries, BMI 23 to 25 considered as increased risk for overweight. So it is a trigger point for lifestyle modification. So we have, as primary care physicians, we have to identify this category. So this is when it's 23 to 24.9 or 25, we have to identify it as a trigger point for lifestyle modification of this patient. And when it's come to waist circumference, in Sri Lanka, according to the guideline of Sri Lanka, issued by Ministry of Health in 2018, its waist circumference for male is more than 90 centimeters, and female it's more than 80 centimeters. That was the cutoff point. So as I told you, the BMI correlates with the body fat mass, and in Asians, the distribution of fat is very important because the fat distribution is mainly around the abdomen area. So the waist circumference is also very important when we assess obesity in Asians. And it says abdominal obesity is higher among Asians than Caucasians for given BMI. So Asians develop obesity-related complications at low BMI. The same thing in the other sentence. And apart from the total body mass, the following aspects of obesity have been associated with comorbidities. So other than the BMI, these things like fat, where the fat is distributed, the weight, circumference, and waist hip ratio, and age onset of obesity and intra-abdominal pressure. Those factors are influence in the complications of the obesity. If the age onset of obesity is, for example, if the age onset of the obesity is younger age, the complications are more, even though the BMI is considerably not that much high. So those factors are also important other than the BMI. If I brief some complications related to obesity, endocrine and metabolic diseases associated with obesity are metabolic syndrome and dyslipidemia, cardiovascular disease, hypertension, cerebrovascular and thromboembolic diseases, pulmonary diseases, restrictive lung disease, and obesity hyperventilation syndrome, and obstructive sleep apnea. GI diseases, gastroesophageal reflux disease, gallstone, pancreatitis, and liver disease. And also neurological diseases, stroke and idiopathic intracranial hypertension. And there are other diseases like GU diseases, PCOS, and complications of pregnancy and urinary incontinence. And musculoskeletal system, gout, osteoarthritis. And when it's come to cancers, there are more than 10 cancers associated with obesity. The main cancers are breast, colon, and rectum. So you can see all the systems are affected when you are obese. You are at risk for a lot of chronic and acute illnesses when you are having obesity. So when a patient comes to us in to a clinic with obesity, what are the things we need to ask in the history? The main points I have pointed out here. Weight history from the birth is very important. If it is there from the childhood, it is very significant because it gives rise to more complications and more comorbidities, and the control is a bit difficult when the weight is more from the young age. And we have to get a good history of current eating habits. How many meals he consumes, how many calories that contains in that meals, and triggers of eating. Because some people eat not because they are hungry, due to stress, because of the social interaction, they tend to eat. So we have to dig into that history also, and their physical activity and psychological aspect of eating behavior. Why they eat? Is there any other reason for them to eat, like stress reliever? And assessment of patients' motivation, readiness for change, and expectations. That also we have to assess in the history. And not to forget the presence of obesity-related complication, whether he is already having the complications of the obesity. Like in our patient, he is having early osteoarthritis. And when it comes to physical examination, yes, we have to get the measurements of obesity, the BMI and the waist circumference, which can be done in our clinics, and the features of insulin resistance, because when the obesity comes into play, there's inflammation in the fat tissues. Those inflammation release cytokines and tumor necrosis factor and a lot of substances which reduce the sensitivity of the insulin. So they become insulin resistant, and features of insulin resistance like acanthosis nigricans, skin tags, those things appear. And other than in physical examination, that thing, the features of obesity, we can have to find whether there's a cause for the obesity. Like if the patient has hypothyroidism, we can see the features of hypothyroidism in the examination, like facial puffiness, dry skin, bradycardia, like that. And in PCOS, if the patient has PCOS, we can look for hirsutism and hyperandrogenic features in the patients. Like that, if the Cushing syndrome, we can look for the features of that. So in the examination, we have to look for if there is a specific cause for the obesity. And if the patient is a child, we have to look for genetic syndrome also, because syndromic obesity is there. And other than that, we have to find out whether there's a complications of obesity by checking blood pressure and features of osteoarthritis, any heart diseases, for the dyslipidemia, eruptive xanthoma, like that. And not to forget, we have to assess the coexistent cardiovascular risk factors. Because obesity is independently a risk factor for atherosclerotic cardiovascular disease. So we have to assess whether there's any other risk factors in the patient, like smoking and family history of diabetes mellitus. So as I told you, it's an independent risk factor for atherosclerotic cardiovascular disease. What we use is WHO risk assessment charts for cardiovascular risk assessment, but obesity is not a risk factor in that there. But if we take other risk assessment tools, for example, Q-risk score, the obesity is a main risk factor. So, but it is not used in our country, not validated to our region. The WHO charts are the ones we assess. So when we come across an obese patient, it is very important to assess the cardiovascular risk. And sorry, I have listed the history component. I told you the drug history is very important, whether patient has been on long-term steroid or drugs like alpha-9-ureas or the contraceptives that cause obesity, and the family history of obesity, for example, in genetic syndromes, and weight of the children, that also important, and previous treatment and management strategies, if they and their success, whether the patient has undergone any interventions for the obesity management earlier before this encounter, and the success of that is very important to ask in history. So the basic investigations, we have to do an investigation to find whether if the clinical history and examination suggest a cause for obesity, we have to go along that pathway and do specific tests to find out is there a cause for the obesity. For example, thyroid function test, cortisol suppression test, and testosterone level, and ultrasound scan if we suspect PCOS. And other than that, we have to look for other comorbidities like diabetes, doing fasting blood sugar, and dyslipidemia, lipid profile, and fatty liver, and problems with NASH, doing liver enzymes and things. So we have to do those basic investigation. I forgot to mention here, ECG is very important because those people are having high risk for cardiovascular disease. So when it's come to management of obese and overweight patients, there are 5 management strategies. So the first one is the dietary intervention. The second one, physical exercises. Third one, behavioral therapy. Fourth one, pharmacotherapy. And the last one is the bariatric surgery. So the obesity is an imbalancing what we take and what we spend. So if we take more to our body than we spend, obviously we get fat. So the main component here is dietary intervention and physical exercises. So we have to reduce the input and increase the output. So among that too also, dietary intervention is very, very important according to the latest evidence-based medicine. Researchers says that dietary intervention is the most important thing when it's come to the management of obesity. For you to get an idea about how the weight reduction improve our health, if we can reduce more than 5% weight from our body, we can improve our glycemic control and reduce the use of antihypertensives, statins, and insulin dose. And it reduce urinary incontinence and reduce the sleep apnea and the fatty liver. And it reduce kidney diseases and it reduce depression, and our body image dissatisfaction is also reduced, and it improve our quality of life and physical function and sexual function. So I told you the main managed treatment is dietary intervention. So it for us to reduce our weight, it needs high intensity comprehensive lifestyle intervention. So the first one is dietary modification. So usually for female, the daily caloric requirement is about 2000. For male, it is around 2500. So if we can have a deficit of 500 kilocalories per day, we can achieve this 5% weight reduction in 6 months' time. That is what guideline says and what is the evidence-based medicine says. So for us to have this much of weight loss, we need to have 500 kilocalorie deficit need to continue to have that much of deficit. So what are the recommended diets? We know there are now in our society, there are a lot of diets. There are a lot of fat diets, but those fat diets are there and they are also effective, but for a very short period. The researcher says that there are no long-term benefits with the fat diets. They are only having short-term benefits. But if we can have balanced low-calorie diets and low-calorie version of healthy diets like Mediterranean diets, DASH diets, is evidence-based diets to have reduce the weight, and low-fat diets, low carbohydrate and low glycemic index diets, high protein diets, and very low calorie diets are diets that are shown to reduce the weight. And other fat diets are, yes, they reduce the weight, but very short term. Long term benefits are not shown, and they have a lot of adverse effects also, like cardiovascular adverse effects and malnutrition, mainly micronutrient malnutrition, like that. So they are not recommended in the guidelines. So even though those low-fat diets and things are there in nice guidelines, in our guideline, this is the plate they have advised to take. So you can see rice portion is there, and the other nutrients like proteins, vegetables, and other things need to be there in our plate, reducing the amount of rice. So this is for a normal weight person with a normal BMI. If the patient is obese or overweight, the the carbohydrate component further get reduced, and the other nutrients amount is getting increased, like vegetables, salads, fruits, and proteins. So this is the plate they have recommended because our main meal is rice and curry. So this is the one they have advised for our patients. So this can be, we can have a picture of this in our, if we can have a picture of these diets in our clinics, we can demonstrate it easily to patients, so we can easily explain the patient what is the diet should be. And the second one is the exercise. So what exercise do is it can't do a big weight reduction, but it increases our metabolic rate and maintain the weight we have already reduced. So exercise is very important. So for average weight reduction, I mean for us to get more than 5% weight reduction in 6 months, we need to have a 150-minute moderate intensity aerobic activity for week, or 75-minute vigorous intensity aerobic activity. And other than that, we need to have muscle strengthening activities 2 or more days a week. That is the exercise or the physical activity they have recommended. And the other component is the behavioral therapy. So when it's come to behavioral therapy, it's a very important part. The goal of this behavioral therapy is to help the patient to make long-term change in their eating behaviors, and by modifying and monitoring their food intake, modifying their physical activity, and controlling the cues and stimuli in the environment that trigger eating and overeating. So it's basically changing the how we live and how our food pattern, our physical activity pattern, and our social interactions, doing some behavioral changes to that is the behavioral therapy. And it is very, very important. And what is the most important thing here is we can advise about the diet, and we can advise about the exercise, and behavioral therapy is also something that primary care physician can address. So when it's come to behavioral therapy, the main elements of behavioral therapies, the nutritional education. Here what we have to do is we provide the motivation to the patient why we lose weight and how we lose weight. So we have, when it's come to why, because we have to educate the patient the adverse effects of obesity, the complications, things, and how to reduce the weight. For example, when we advise patient to reduce the calorie intake, we can ask patient to take more water instead of sugary beverages. Like that, we can give the nutritional education. So it shows that the patients who receive weight loss advices from healthcare worker have more chance of weight reduction and more chance of to have behavioral changes. So it is the evidence shows that it is very effective when we are giving the healthcare workers giving nutritional education. And the second thing is the self-regulation. Self-regulation includes set of supportive behaviors. I'll list them first and I'll go one by one. The first, these are the things that come under self-regulation: goal setting, self-monitoring, controlling or modifying stimuli that activate eating, eating style, behavioral contracting and reinforcement, meal planning, cognitive restructuring, and problem solving. So when patients come to us, when we address the behavioral therapy, we have to set a goal for the patient. And that goal should be very specific and patient-centered goal, and it is achievable. It should be achievable thing. For example, we can set a target like we can negotiate with the patient actually. What about we are losing 500 grams per week, or like losing 5% to 10% of base weight from your baseline in 6 months, like that. And this goal should be very individualized thing. We can apply it to each and every patient, because it is like patient-centered goal should be there. And when it's come to self-monitoring, the main thing is having a food diaries. We can ask the patient to keep documents what he eat, at what time he eat, what amount he eat, and have a record of that. So when the patient comes to us for the reviewal, we can go through his food diary and analyze if there are any pitfalls and things, if there are anything we need to adjust. And there should be activity records also, what he does for exercises, and self-weighing and regular weighing. That is how we encourage patient to do the self-monitoring. So for these monitoring, we can use paper diaries, internet applications, or smartphone applications. There are smartphone applications for these food diaries and activity recordings. And when it's come to stimulus control, as I mentioned you before, the food eating is not only for the hunger. For some people, when they are happy, they eat. They are angry, they eat. When they are sad, they eat. So we have to identify the trigger, the stimuli, and control the stimuli. And we need, if there are trigger factors, we can eliminate the trigger factors. And for as simple measures, we can, when there's, when the foods are available, if the high-calorie foods are available in our house, we tend to eat them. So instead of buying high-calorie food, we can buy low-calorie foods and place them in our fridge. So we can make our house a 0-calorie house, like no high chocolates, cakes, and things, but there are fruits and salads and vegetables. So if the high-calorie foods are not available, we won't be eating them. And the other thing is concentrate on eating. Like some people tend to eat with while watching TV or with reading, so that invariably they are taking more food when they are doing something with eating. So it says we need to concentrate on eating, and we need to turn off the TV and put down the reading materials. And the other thing we need to address is eating style. So slowing down eating process may give time for physiological signals for fullness to come into play. That means if we eat slowly, our brain recognizes now we are getting full. When it's taking time, our brain thinks now he's taking time, so he's now full. And the other thing is mindfulness, mindful eating. It says that we need to concentrate on the taste, textures of the food and the savorings. And we have to eat slowly, chewing and eating very slowly. And another trick is we can drink water in between, or we can leave the table for short time during a meal. Those things are also there under the behavioral therapy. And the other thing is the cognitive restructuring. It says that adapting positive rather than negative self-talks, having a good image of yourself, and problem solving mechanics like if you are stressed and you are eating, we need to improve our problem solving ability so that stress won't be matter for us. And the other thing is we have to we need to learn to say no. If someone is offering us something and we are on control or a plan to reduce weight, we need to have the courage to say no. And the other thing is, as I said before, the stress reduction. Identifying and reducing the stresses that trigger the eating. Those comes under the behavioral therapy. And as you can see, it's a very simple thing that we can do in our primary care setting. And this is the food diary I have told you. This is there in our national guideline. And this is the management plan they have given. This is what I actually briefed you earlier, the dietary, exercise, and behavioral therapy. And the fourth component is the pharmacotherapy. So who are the people who need drug therapy? So it says people who are BMI is more than 25 with one or more obesity complications, we can offer drug therapy. Or people with BMI more than 30, even without comorbidities or complication, we can offer pharmacotherapy. So these are the drugs that are available for weight reduction. Even though there are a list of drugs, most of the drugs are not practiced in Sri Lanka or licensed in Sri Lanka for weight obesity management. But they are there in the literature and evidence-based medicines to practice for obesity. The drugs that we use in Sri Lanka is most of the time it's Orlistat. It's a lipoprotein lipase inhibitor. So it reduces the fat absorption from the bowel. It's usually taken with meals, and about more than 5% weight reduction can be achieved over 1 year with Orlistat alone. And the problem with Orlistat is the incontinence and fecal urgency. The fat things discharge without notice. So there is a problem when it's come to people who work outside. So that is the main reason that why people are reluctant to take Orlistat. And there are other drugs like GLP-1 receptor agonist, which is a drug that originally came for the management of diabetes, the liraglutide drugs. So that it also gives a big percentage of weight reduction. It says 5 to 10% over 1 year. So if the patient is having diabetes, if our patient is having diabetes with obesity, we can prescribe this GLP-1 agonist if the patient can afford. So the problem with GLP-1 agonists is they are a bit expensive. The other drugs are there, but they are not licensed for obesity management in Sri Lanka. So if I brief the indicators for bariatric surgery, it says the last option. If all are fails and patients are indicated for surgery, we need to refer them for surgery. It's because, as I told you, obesity is a disease that we need to treat. If the BMI is more than 35, even there's no medical problems, we need to refer the patient for bariatric surgery. And if the BMI is more than 30 with below comorbidities, we need to refer the patient for bariatric surgery. So there are things that contraindicated for bariatric surgery. I think you can see them. There are bariatric surgery types like sleeve gastrectomy and mini gastric bypass. I'm not going to go into details. So when it's come to our patient, he's having obesity and he's willing to make a change in his problem. So he's already willing to do the lifestyle modification, the dietary changes, and he's already a physically active person. So what we did in our patient is we give him a nutritional plan and we referred the patient to the nutritional clinic. So they gave him a good plan and we advise on his continuing his physically active life, and we gave the behavioral therapy also. So even not only I told in history you saw that he's eating 6 meals per day. So he's eating because he's stressed, because his wife is disabled and he has to take care of his 3 sons. So we addressed his stress issue also. And other than that, he was willing to take the Olistat. And he could afford it. And we explained him about the side effects. As he's working at home, he was willing to take the Olistat. So we prescribed him on that also. And for further management, we asked him to do the other investigations like to find a cause for the obesity like TSH, but we couldn't find any cause for the obesity. So we thought his dietary habits and the lifestyle is the main cause for obesity. So we are following up that patients. I think we can have a good result from this patient. So what I want to emphasize here is the obesity is a non-communicable disease. So it can be successfully addressed in our primary care. So we can prevent it, we can treat it, and we can have a good long-term success in this disease. So I hope you have got something from my presentation. If you have any questions, I'm willing to answer.
I would like to comment on it. Right, it's a good presentation, Gayatri. Thank you very much for that. But as we discussed this patient in our clinic, most of the important aspects of the obesity management has not been included, I think. Sorry to mention about this because this is for the learning purposes and it's called the reflective learning, that you have missed some points and get to know it with trainer and then you are going to correct it. So throughout your learning process, it has to be reflective in manner so that to improve your gaps. So here I find that you are more focusing about the management of obesity towards the lifestyle and the behavioral, right? one thing. And the second thing is, even though you were talking about the behavioral this thing, you were mentioned the most important points among Sri Lankans, that males around this age, they are the bad, the habits like alcohol, smoking, which can contribute to the complication of the obesity with other the comorbidities. It gear for other comorbidities. So because of that, that is another thing. And this patient, particularly our patient, I can remember well, he is not only the hypertensive, as well as he is the pre-diabetic as well, right? And he is having obesity on top of that. And the patient is having social, the worries as well, which we need to think in terms of the management of the patient at the end, in a comprehensive manner, right? Because he is having family issues, we have to be patient centered as well as comprehensively, because family issues are also there. And he is a mason, or carpenter, he needs to the work as well regularly. So those are the important things. So whenever you are get a case, right, main thing is whatever the guidelines, the mention this and that, so you have to absorb the guidelines specifically to manage your patient in a, the identify the patient problems, and then, the identify the underlying the issues of the patient, and then manage the patient accordingly at the first contact care level, right? So first contact care level in Sri Lanka, in the government sector, we are in the base hospitals, and sometimes you can, though they get another district general also, now they are there. So with lot of facilities like the other countries, so the diagnostic services facilities are very much, the luxury for us to, the come to the identify the patient's underlying cause regarding the obesity. Very firstly, whenever the patient comes, you focus about under those 5 skills. In your data gathering skills, you focus about the patients in the presenting complaint and the secondary causes due to this, the symptoms of complication, which Gayatri very nicely explain about, this patient is having early osteoarthritis of both knee joints, and as well as pre-diabetes at the very first time she mentioned. So having, the identified those issues and the social issues, that his wife is suffering from rheumatoid arthritis, where he needs to support his sons, and he's the breadwinner as well. That is also another problem. So, and income, he says it's okay. So you have identified all the problems, but towards the end of the patient management, it should be focused for the patient such issues. That is the patient-centered management. So once you get the correct, the histories and excluding red flag symptoms, because always you have to think about, I told you, the secondary causes, the possible serious cause, right? With obesity, what are the serious causes that you have to think about? The underlying cardiovascular issues like TIA, history of TIA, then history of the chest pains, right? And as well as the thyroid symptoms, mostly hypo. And then you have to ask about the possible causes, like he's man, so no point of asking about PCOS. And the finally you have to ask about the complications, history for to exclude the complications, like the complications and the underlying causes, right? So with that has done that job very well, right? All psychosocial history, physical and red flags exclusion was done very well. Examination also very good. She is much focused about, the BMI, the hip waist circumference ratio, and as that well a thyroid examination, and looking for other the underlying causes as well, the renal balancements, and those things you have to, because he is having hypertension as well. Anyway, then But in management, I feel that you have not focused much for the patient-centered management to address those issues, right? Because now patient is the breadwinner and patient is obese, and we have to find underlying any secondary cause. So for that, we have, investigated the patient correctly with all the set of investigation, thinking about to find out possible underlying cause as well as to find out the possible complications of the obesity, like, the CVD events, the renal functions, right? Those things we have done correctly. I can remember very well. So, but this patient, we found only problem is for the complication, more towards complication is his pre-diabetes. So this is where the first contact care, opportunistic health prevention comes into play, which is very, very important because he is a breadwinner and he is obese as well, and he is pre-diabetes as well, and hypertension and psychosocial issues. So your role must be to identify the encounter, to manage the main encounter as well as prevent that patient going into complications. Now it's very clear the patient is pre-diabetes, where you have to take the very important guideline based management to prevent this patient going into the diabetes, where the dietary, the manipulations matters more. But in case of, I found that in case of counseling of the patient, it was not the enough, the explanation was done to the patient so that patient will realize the realization of underlying problems and the risk will, take the patient into very good compliance plan. So because of that, we would have, you would have explained to the patient that there is a higher risk of, the getting you into the diabetes because you are on the fence. So in such a case, both, the diabetes control, the coming into diabetes as well as the hypertension and the weight reduction would give you the best option for these things. So because of that, the patient will be more concentrated towards the management of, the patient's diet, where you have to show the risk and then advise the patient, which is very, very useful for you to get the patient into the compliant, the management plan. And this patient, we have sent this patient to assess the cardiovascular. We have assessed the cardiovascular risk. And Gayatri, what was it, the cardiovascular risk? Because after getting, after getting the patient's the lipid profile and these things, we have done that. I think I can remember.
Yes,
Gayatri,
madam,
can you?
it came as less than 10%. Hello?
Less than 10,
Hello?
no? Yeah.
10%, yes, madam. The problem we discussed that time also, madam, our tool, the WHO risk calculator tool is not very comprehensive. It disregard the obesity.
No, that is, we are always, you have to, always investigate such a patient to identify the cause for the obesity as well as to identify the prevailing underlying complications which we can't detect by the symptoms. So those are the two things. Always you think about, if you find the problem, obesity is the disease that's highlighted very well. So if you see a patient or your relation being the first contact care people, and you are going to get the proper training to become a consultant, so you have to think about, this is the disease where we need to treat. Unfortunately, our people are not aware about that this is a disease, right? They just, they take it lightly. From that point onward, your, the knowledge application will start to the patient. So you have to clearly tell the patient, by establishing a very good doctor-patient relationship, it matters here very much. The giving the comfortable room, consultation room, as well as calling by the patient by name, and always asking open-ended questions, whenever only necessary the close-ended questions, and summarization of the problems like that, and keeping your medical record properly. Those are very important for such a patient, because we need to take the patient into the management plan in long-term basis. So the second thing is identifying, the underlying cause by, the having the proper differential diagnosis and excluding those things by red flags as well as from the history, right? Then examination, then counseling. Counseling part very important here. And the Gayatri has given a nice, the knowledge about the dietary, how to do the dietary manipulations, and what are the possible, the 500 kilocalories if we can take out from the patient, and the maintenance of the diary, food diary, as well as the activities is really, really good, which is very important, and it's new, but if it works well. So if you can introduce for the patient who can understand, because the poor people, they can't, but in patient, middle class patient, having diabetes, obesity, and then we can get into the compliant plan by, going through that, taking out the more, telling him, educating the more calorie diet. So because of that, that's a very good point that she highlighted here, 2 points, right? And but always I'm telling you, the counseling is very important skill that you have to master. So at the end of the exam, as well as when you are going to practice day to day, you have to, tell the patient what this obesity is and what is the importance of, correcting this, and you are going to identify the possible maximum risk that the patient is currently having, because it may be different from patient to patient. So another patient will be having, the cardiovascular events, right? Not the diabetes or pre-diabetes. So then you have to think about the managing those things with the multidisciplinary team approach by sending to the necessary, the specialist for the cardiovascular event assessment or their opinion, and the nutrition, here the exercises program, those things at the exam. So please, even at our setup also, we send our patient for the nutritional advices, as well as we give them the guideline for the low calorie diet, and as well as we refer them for the osteoarthritis patients, early osteoarthritis, to prevent them going into the chronic stage by referring them to the physiotherapy, and whenever they come for the next visits, we are going to ask about the progress of the physiotherapy, because this is not just, the one advice will help you. You have to reinforce always with the patient in a helping way, right? Reinforcement is very important for the dietary, exercise, and other things, and the prevention of the secondary causes, if any, like smoking, the alcohol. Those are also very important to, the address to prevent, such underlying, the complications of the patient who is having obesity. So those are very important. Investigations wise, she mentioned all, because cardiovascular health we need to assess by ECG and 2D echo, and exercise ECG possible. And the second important, if can't, that we can advise the patient, the cardiologist, to do the 6 minutes walking ECG, that also like exercise ECG. And the other thing is, the renal function assessment, and then the patients, the hormonal functions, in if like thyroid and cortisol if necessary, right? It depends on the patients, the history and the examination, it matters more. So you have to master your skill in history taking and the examination to find the correct underlying possible clinical diagnosis. Then you can limit your investigations, right? And she has done all the relevant investigation, lipid profiles, and as well as the fasting blood sugar. We have done HbA1c if possible, that is the base, right? So accordingly, we have detected the patient and we managed. I can remember very well, we have informed his, the prevention of diabetes as well, right? Is it, Gayatri, even though you didn't discuss here?
Yes,
Pre-diet.
madam. Yes,
And
that's
the OA, because so for such patients, we have to give them the tailor-made exercises like quadriceps, it's not the walking, because with obesity, if the patient walks very much, right, then his obesity will give the problem, the progression of the OA of both knee joints. In such patients, we can advise them to go for the aerobic exercises like, the stretching, and it matters more, right? It reduces the weight as well to reduce calories. So it's not when you are going to the exam, you are telling that I will advise for you to walk. That is not the correct thing, right? If you reduce the weight only, you can advise for walking, but rather than walking, you can advise them to go for the stretching exercises, right? That is really helping to reduce the weight as well. So those are the very important points. And to the repeat, the monitor the patient for the diabetes as well in 3-month intervals by doing HbA1c or fasting blood sugar and ppbs, and the lipid levels, right, regularly in at least 6 months. Otherwise, we do on hypertensive patients without any CVD risk, we do 1 yearly. But here, the lipid profile also need to be done, right, in 6 months intervals, whether we need to check, because it's already patient is having fatty liver, right? It starts raising these enzymes. So with weight reduction, as well as the patient is willing to go for Orlistat because he is working at home, so that will helpful. But reinforcement for the the whole the program of management of weight reduction, monthly monitoring of the weight, and as well as the going through the food diary, and if possible go for the calorie diet to reduce in the way that patient can, always with negotiation you have to do. And follow up is very important. Non-pharmacological is very important here. Pharmacological management also we can. And the CVD risk assessment, because such obesity patient, if you get, you have to check what are the underlying possible cause for this, because sometimes it may be the overeating, or sometimes it may be secondary underlying cause like hypothyroids, or it may be due to the abnormal behavior like the more restaurant food eating and the liquor and those things, and smoking may be there to give them another additional risk. So you have to assess that, and you have to always manage according to the patient's the underlying cause. That is the patient-centered management, right? So your book management will not matter for each and every patient. So you have to identify clearly what this patient has, and what is the health risk in future, and what is the complication that patient is going to get to already got. So in such a way, then you have to manage. Okay. So if the patient is having cardiovascular issues, then you have to send the patient for the cardiologist opinion. And in case of the osteoarthritis, we can manage here. But if the patient is having effusion or history of falls, right, tend to falls with walking, right, then we have to send the patient for the orthopedic, the opinion to identify in which stage this patient is, because the arthroscopic assessment will be needed. So those are the things. And the nutritional, that is called multidisciplinary team approach according to the patient. So always assess for the cardiovascular risk, renal risk, and that is called organ damages, right? You have to look for that, and as well as the any existing the risk for the future problems related to this obesity. So obesity management, the underlying cause management, and underlying complication management, and underlying risk management. So those are the things. But I have noticed whenever you all are coming to the exam in such the patient, you are always talking about the diet, exercise, those are the things. So that is not your management. That can be done through the multidisciplinary team approach. But you have to find out why this patient got obese, and as well as what are the most imminent cause for this patient to got this obesity, and what are the health risks that patient is already having, right, more than the obesity related health risk, and any other complications this patient is having, where we are going to manage the obesity at the end of the session. And you have to find out, you have to correct, the risks. If the patient is having some health risk, how you can do it, and the early treatment for the complication and the correct the referral in order to prevent them going into the bad stages of those complications. So that is the management of obesity. So the next time, the class will practice 2 OSCEs of 2 obese patients, right? So because otherwise it's not a the complete session. So during the previous registrars are Prabhat and the Gayatri. So we will the properly the train for that, we three together, me and we three together, and we'll show you the case scenario. It's the role play, right? The way that you have to do your day-to-day, the patient consultation, as well as to more focus for your exam preparation. Okay, so those, then it's open for you to ask questions.
Thank you very much, madam, for your feedback, and it's very very comprehensive explanation, and I will improve my consultation and counseling skills, madam. Thank you very much.
So thank you, Gayatri. You have done a good job. So any questions? Now the crowd has limited, gone down. It was almost 40, now 25. Maybe sleepy. Any questions for you all to ask? Chaminda? Dilini?
Madam, in this patient, BMI was 30. Oh, what was the BMI of this
36,
patient?
no?
36.
Yeah.
Yeah.
In that case, we can offer him bariatric surgery also. I think patient may not
Yeah.
like to that thing.
Good. Yeah.
But did
Yes,
you
but
ask about
first we
the?
have to
Did you ask about?
do the dietary and exercise thing, and before doing that, it is no point on going to bariatric surgery. If that fails, we can in stepwise manner we can go to bariatric surgery.
Yeah, guideline says, Chaminda, this is because if the patient has not tried those other interventions like lifestyle, dietary, behavioral changes, then the final this thing only, we have to go for the bariatric surgery, right? And
Okay.
in case of bariatric surgery, good that you raised the problem, because I have seen the patients who have undergone for the bariatric surgery, right? So bariatric surgery, even though we send our patients, so once you do that, because absorption capacity will be very much less. So they have to be depend on vitamins every day, right? Supplements and sometimes the protein supplements. So other than that, I have seen many patients, because as consultants in the first contact care, we have to know that as well, because their weight will drastically reduce, right? With that, that their appearance will go into the very much, the old age look. So if a patient with young age, not this patient is 49, but young age patients, right? If the patient, that has tried this diet and the exercise and the underlying causes have been excluded, right? Then still you have to think about the possible other the reinforcement for the diet, the very the strict dietary manipulation, then very strict the exercise patterns, and the less calorie diet and all, rather than going for this bariatric surgery. Because I have seen it's very it's if I am the person, right, for that to go for that bariatric surgery, right, in around 30s, 40s, I would not go. I never, because it's the knowing the side effects of it. It's really the frustrating. The one patient I met, she told me, right, she's a police hospital worker, WPC. She told me, if I knew this, I never do this scale up, because that much of her appearance has gone down. Health wise, of course, all right, but still you have to depend on lot of the nutraceuticals to take from outside. It even though because they can't eat lot, no, they have reduced the amount, right? The stomach size is less, so very much the less food that they can eat. Satiety center will be the field very saturated very quickly, so they have to, even though they can't go for the enough the vitamin and other mineral supplementation, so which matters lot for the patient as well as the patient appearance because of low carb diet and all. So I have seen many patients, to be honest,